Okay, hi, well, welcome back. This is the final Thank the Lord webinar of our 7-part webinar series on chronic care models. 7. You could have really just skipped all the others and just gotten to this one if you wanted to, because I hope, well, I'm not sure. You tell me. Maybe we saved the best for last. I'm Dr. Eric Vanderlip. I'm a family physician and psychiatrist. I'm at the OU School of Community Medicine. I'm in the departments of medical informatics, psychiatry, and family medicine. And I care a lot about figuring out ways to get people engaged in their care. This is part of our 7-part webinar series on integrated care and chronic care models. We've talked about the notions of integrated care, its bidirectional relationship, the need to better approximate chronic disease measurements or models that do good chronic care management because our entire population is shifting this way. This is the bulk of healthcare. Models that do this better in integrated care are called collaborative care. They utilize a team that takes care of a population of patients on a registry which holds measurement-based outcomes, and that team delivers evidence-based care to get those measurement-based outcomes better. And we can adapt those models into safety net settings by just redefining what our outcomes are and what team-based skill sets are needed to do that. In order to support that team and keep it going, the biggest barrier is recruitment and retention. Recruitment is a component of finding the right people and giving them the right education, and retention is a component of preventing burnout, which requires a good system that can avoid tyranny of the urgent. And a good system allows those teams to see their changes in measurement-based outcomes and have the evidence-based skill sets around them to affect those changes in measurement-based outcomes. And so these collaborative care models and chronic care models are good ways to steel teams and resources against burnout and turnover and retention, which is one of the biggest barriers to implementing things like your health home model. Finally, though, I have to tell you a dirty secret. The biggest barrier to getting outcomes in any model, any chronic care model, is your team's capacity to engage people and have productive interactions with them. And that is what we've saved our final webinar for. So I'm really excited about this because nothing else matters if you can't figure out as a team how to work with people and partner with them and engage them in their care and meet them where they're at. The world of behavioral health has much to offer in this space, and I'm excited to showcase that for you today. Some of you already know this, but we also take it for granted. And in the world of behavioral health, we really sometimes give lip service to things that we'll be talking about in this webinar that are so absolutely essential to the future of medicine. We'll go through them. I don't have any disclosures. Yeah, so we got this problem. This is the Global Burden of Disease study looking at, well, this is just within the United States, the disability adjusted life years, 2013. All this blue stuff, non-communicable illness. Remember, this thing in the middle, diabetes, going up in the world. Diabetes is, and rethinking how we approached our care for diabetes is what gave us the chronic care model, which I'll show you in a second. This is the actual risk factors underlying those outcomes. And when you look at these risk factors, it's behavioral risk factors that we've talked about before that are primarily determining if you will live to the ripe old age of 50 or the ripe old age of 80. And those behavioral risk factors are running and exercise, alcohol use, tobacco use, et cetera. So remember that article that I showed you in the last webinar by Scharf et al. From Psychiatric Services 2013? This is the same article. And I had said that retention and recruitment of staff was one of the biggest barriers to program implementation and follow-up at 1 year. But actually their biggest barrier to anything, the most salient barrier at follow-up was difficulty recruiting consumers to participate and then keeping them enrolled at a year. Really, really hard. Really, really hard, especially in the safety net setting, when people are they live very scattered and chaotic lives, and their priorities, oftentimes by necessity, are elsewhere besides you in the healthcare system. They're with friends and family and supporting them, or finding housing, or food, or shelter, or satisfying their basic needs. So, as one grantee said, many clients are referred to the program, but then they will either avoid our case managers' attempts to contact them or they will not show up for their intake. This is fundamentally a problem of engagement. So we've got to talk about that. Turns out that in medicine, engagement in all of healthcare, engagement is the final frontier. If we can figure out how to re-engineer our systems to fundamentally engage people more in their care, we'll have better outcomes, our systems will be more efficient, and we will have longer living populations. When we look at diabetes and it gives us this chronic care model, we're talking about having a system that generates an informed, activated patient, And then this team that we are supporting through all our efforts in the past webinars has to have productive interactions with that informed, activated, engaged patient to have improved outcomes. And an informed, activated patient is engaged. How do you get to an informed, activated patient? You have to have self-management support, which is AKA health literacy. But you've also got to have something else that they really hadn't identified yet in the chronic care model, which was productive interactions as a necessity to engage people and activate them in their care. So this is from Health Affairs. This is a policy brief. And it actually said this. This is a policy brief on patient engagement. And I'm going to just read this. It says, Coe and colleagues propose, for example, that healthcare organizations first adopt, gasp, the chronic care model to provide comprehensive care for chronically ill patients. Then health literacy strategies would be incorporated into the model, such as the teach back method, which is one method of making sure that somebody, when they teach it back to you, they really seem to know what you've told them. They're now literate, and now they can be more educated. Now they're more educated, now they're more engaged in their care. So health literacy is one essential aspect of engagement. The chronic care model calls this out, and they identified this in this Health Affairs article, 2013, on patient engagement. So having a system like the chronic care model that bakes into it education and health literacy is essential. Many of you do this already with our psychoeducational programs, and this is part of recovery in the recovery model. But it's absolutely essential for chronic care to have this informed, activated patient. It's now 3 p.m. So when we also think about the totality of healthcare reform, and I've shown this slide before, all of our efforts are somehow aligned with getting people more engaged in their care or building the systems to engage people more in their care. Or it could be looked at that way. So things like behavioral health homes, that's what you're doing. Integrated care, health behavior change, that's engagement. Patient-centeredness is engagement. People aren't going to engage in a system that's wholly fragmented and doesn't serve their needs. They just won't come back. Self-management support, health information, other things. So I'm going to take a little bit of a left field for just a second and talk about some different stuff, because in order for us to really approach populations well, we have to overcome some of our own thoughts and feelings about them and overcome some of our own presumptions about them. And even in the world of behavioral health, where we want to be trauma-informed and think that we're open and welcoming, sometimes we're not very well. So we have to talk about a few extra things. This is a picture of a canary in a coal mine. And it could be that, and what I'm going to share with you is that it could be that our problem patients, our most difficult patients, and our squeaky wheels in our healthcare systems are really the people that are like our early warning signs to our system not working very well. They're kind of the outliers. And if we pay attention to those cases and we listen to what they're telling us about our healthcare system, we have a lot to learn. So let's examine problem patients for a second. But I'm going to come at this from left field and talk about something different than directly talking about problem patients. I'm going to talk about attachment theory. So attachment theory is, and this is a picture literally of left field. I don't think that's me coming out of it, but it's somebody. And I get a lot of this from one of my old colleagues and mentors at the University of Washington who talked about this in their chronic care models, because this is so absolutely essential to us rethinking how we engage people in their care. Just a fundamental understanding of some attachment is so essential. So who is this? This guy's name was Konrad Lorenz. Konrad Lorenz was a dude who used to go out and feed ducks. And then after a while, these baby ducks stopped following their mom, started following him. He came up with this theory called imprinting, that at a very early age, a young person can form an attachment to something else and get sustenance and resources from that other thing. And it's not always its biological thing. It's whatever is giving it its secure reinforcement, sustenance, nurturing. Imprinting and ethnology from Konrad Lorenz led to this dude thinking up this thing called attachment theory. This guy's name is John Bowlby. And I'm not really big on old white guys and talking about old white guys a lot. But it's important to understand where some of this came from because I think it helps us remember it a little bit better. What was attachment theory? Attachment theory is basically a study of how human beings respond within relationships when they're hurt, separated from loved ones, or perceiving a threat. This is healthcare incarnate. The only reason people come into healthcare clinics and systems is when they're hurt or perceiving a threat. Their leg fell off, they're having a heart attack, they're scared, they're vulnerable. And attachment theory is a study of how human beings interact. If we can study how we interact with each other and know a little bit more about that and these interaction types, then that can give us insights into how we can interact with people and have productive interactions that can lead to informed, activated patients. This is a picture of 3 Men and Baby. That's all I'm going to say about that. In attachment theory, you have a self and an other. And so you have to picture a baby being born. And let's say it's a caregiver. I'm going to be prototypical and say it's mother. Sorry, but that's just what I'm going to go with. Baby, mom. Self and other. And then out of these things, you can get two distinct possibilities on either end. That in terms of the self on the left, over time, when this baby interacts with its caregiver, it will either get a view or a sense of itself that it is good or a sense of itself that it is bad. And conversely, it'll get a sense that the other, the nurturer, the caregiver, is either good or bad. We build this construct early on in life, by the time 3 Men and a Baby is done. And there's 4 different relationships between here that define our 4 main types of attachment theory. So when the baby consistently gets good feedback from the caregiver, that it's always there, that it always gets the bottle, that it always gets cuddled when it's crying, then the baby both thinks of the caregiver as positive, always meeting its needs, and then the baby feels worthy of asking for help, and because it senses that it's going to get the need met in return. This is a secure attachment relationship, when both the self is positive and the vision of the other is also positive. When the other is viewed as negative but the self is positive, when the other never meets the self's needs, then the attachment style is called dismissing, which means that I learned from an early age that I dismiss the help of others. I can kind of go it alone because I don't need their help, because I learned from an early age that I would just have to find my own bottle or nurture or cuddle myself to sleep. When the self gets intermittent reinforcement from the other, then the self starts to think that it may not be worthy of always getting help. But if it perceives the other as positive sometimes, then the attachment relationship is something called preoccupied. And the self overvalues the other and comes to depend on the other maybe too much. And finally, when the self and the other are both negative, that's where it's also termed chaotic, where there's really no good relationship at all. And the engagement pattern is all over the place. These are the 4 main relationship styles in attachment theory. And then they can be put on this grid. So you've got preoccupied, where you've got the model of other, which is positive or negative, model of self. So for secure, you've got positive and positive. For preoccupied, you've got negative self, positive other, etc. Turns out that this stuff matters. It matters a lot in how people come into care. And remember, one of the biggest barriers to getting people enrolled in the PBHCI program was just getting them to the first appointment or getting them to follow up. When they did a study looking at people, asking them this prompt, if I thought I was having a heart attack, I'd wait until I was very sure before going to the hospital. This is assessing how ready they are to maybe go seek help from somebody else. If they viewed the sense of other as positive, they were quick to say, no, I would not wait until I was very sure. I would just go to the hospital immediately. That's what this study is saying. The association here is really strong. When they view themselves as positive, they also seek care. And depression and anxiety and other things. By the way, when they then also looked at their actual risk of having a heart attack, it differed not at all across the groups. So this is for people who had been to the hospital, they'd sought care, cardiac care, and then they looked at whether or not they were really having a heart attack or not. Those who had a negative version of others, those who thought that the hospital would not meet their needs, were much, much, much less likely to seek care and help. These constructs of attachment and how people view themselves as being worthy of care and how they view others as being capable of giving them care consistently inform our relationships and inform how people seek care and services. They also inform how they engage and interact with you. So attachment is a framework through which we can conceptualize patient engagement. And now we can reconceptualize the difficult patient as maybe not somebody who's just a squeaky wheel, a difficult patient, a pain, a gadfly, somebody that's really annoying. But now we can picture them as somebody that's maybe been through this before. Maybe they don't have a good version in their mind, a good schema in their mind that the healthcare system will meet their needs. And so they're afraid to ask. Maybe they feel like they're not worthy of asking. Or maybe they feel like they can do it on their own and they don't need to be helped at all, and they're embarrassed to ask. All these things can tell us a lot, and we can classify people broadly into these groups because it can help us understand their engagement mechanisms better and their patterns better. So at the core of some of the most difficult problem patients that we have are these constructs of abandonment, fear, hurt, rejection. But we don't see that in the healthcare system. And even in community mental health, we have a tendency to label these people sometimes through their missed visits and go-it-alone attitude, or dissatisfaction, poor collaboration. On the healthcare side, this is what we have. We have dissatisfaction. They don't collaborate well with others, et cetera. And on this side, we blame and label people for their failure to follow back up with care and all these other things. Part of it has to do with their attachment and their ability to trust in others. This is part of what trauma-informed care is about. But if we don't pay it good heed, we're missing a big chunk of our ability to engage, a good tool to engage people in their care. So the reason I'm telling you all this is because it's useful. And when you encounter these problem patients in your systems, it's useful to remember that they may be more like a canary in a coal mine. And maybe our healthcare system is what's chewing them up and preying on their biggest vulnerabilities in terms of trust of others and ability to trust and extend an olive branch to say, can you please help me? They're scared to death that we're going to come back and not say something or not do something or not follow through. Those people chew us up. And we've got to be careful that we recognize these attachment styles and do our best to generate systems that overcome those difficulties. Is there an evidence base for engagement? Is there something that we could measure engagement by so we can know that we're getting people engaged in their care? No. It's mainly a problem of measurement. How are you going to measure it? How are you going to know that somebody's more engaged in their care? Do they come more frequently to the clinic? I don't like that very much because that doesn't mean that they're actually taking care of themselves. It might just mean they're coming to the clinic. There are some measures, and one is named the PAM, the Patient Activation Measure, and you can download it here. It's a proprietary thing, so you have to pay to use it, but it's the most widely used measure of patient engagement and activation in chronic illnesses that we have. And some studies that I've worked with make use of this scale to tell us just how engaged people are in caring for their chronic illnesses. So this could be useful. Some recovery scales might also be useful. But we don't have a solid evidence base saying that engagement alone is enough to improve healthcare outcomes. The science just isn't there right now. But what we're talking about is generating this informed, activated patient through productive interactions with the prepared, proactive practice team. How do we get to this informed, activated patient? Well, knowing and understanding their attachment styles, how they might view themselves as being worthy of care and others as being capable of giving them care consistently is helpful so we can have more productive interactions. But I think there's another method we can use to get even more productive interactions and get people even more engaged in their care. And that's this next part. So we have to talk about some tools. The first tool to engage people in their care is simply a registry. And we've been talking about measurement-based care and outcomes and using a registry to identify populations who are not engaging in their care and find them and track them. When people have poor attachment styles, they don't trust that we're going to consistently be there for them, the worst thing we can do is not call them in follow-up or lose them and let them slip between the cracks. Registries allow us to not do that. And then on top of that, they also tell us another thing about engagement. These people in the red here who have not met their measurement-based outcome goals, I know may not be fully engaged in their care. They might be, but that's one of my hypotheses. Either Lucy here is taking all of her diabetes meds, or she's intermittently taking them. And if she's taking all of them, then I'm going to intensify our treatment regimen until we can get her hemoglobin A1C number down. If she's not taking them all, then the other side of the differential diagnosis for why this is still high is that she's just not fully engaged in her care yet. She's not adhering to her treatments as well as she could be because she doesn't believe in them, or I don't know, she's got competing interests or can't afford them or whatever. But we've got to figure out a way to troubleshoot those barriers to getting her to be an informed, activated person to be able to manage her condition on her own. So a registry gives us, in a way, a potential list of people who are disengaged in their care. And then it also allows us to not let them slip between the cracks, which is absolutely essential for overcoming problems with attachment and other things like that in these traumatized populations that we're working with. This is a screenshot of our registry we use on our OU Impact Health Home. These things aren't fancy and don't need to be. Tool number 2 is this. And how often do you feel like this, where we're trying our best to get somebody to go along with us, and we are yanking on the leash and this puppy is not moving? And we yell and scream and scare and nothing ever happens. And it's frustrating to work in this type of a system with somebody that just doesn't seem to want to engage in their care. Even though you've told them time and time again that they've got to stop smoking, they've got to stop drinking, they've got to take their medications, they got to show up for appointments. It's very frustrating. Oftentimes we wish that we were like this, where we had a relationship where we were working together in rhythm and jiving, man. This is so much more fun than this. So this is tool number 2. And how do we get to this with people instead of just dragging them along? What do we do for this? Many of you already know the answer here. It's motivational interviewing. And motivational interviewing is something that I think we overlook in behavioral health because we've had it for a while now. We've had it in the world of substance abuse and mental health services for a while. That's where it started. But it's actually the mechanism, the tool through which we can engage patient populations over time. There's an evidence base behind motivational interviewing. Turns out that Motivational interviewing is not just for alcohol or tobacco or substance use anymore. Motivational interviewing is for a broad set of disorders and can be applicable to a number of different environments. The conclusion from this systematic review and meta-analysis: motivational interviewing in a scientific setting outperforms traditional advice giving in the treatment of broad-range behavioral problems and diseases. Motivational interviewing also works significantly for depression, for diabetes, for all of our chronic illnesses, because it's basically a mechanism to engage people in their care and motivate them to take better care of themselves. Just a spoonful of sugar will make the medicine go down. Just a little bit of motivational interviewing can go a long way. Sometimes we have the perception that we need to sit down and spend a long time with people, but if you have the basic spirit, and this isn't a lecture or a webinar about motivational interviewing, so I'm not going to be going into the details of motivational interviewing, but if you have the spirit of motivational interviewing around you and it is encompassing you, and you have some of the basic tools of it, you can employ them anytime for brief snippets of 30 seconds at a time and be effective and helpful, at least not harmful, in the advice that you're given to people that may be unsolicited. So, and this is saying that it appears that MI may not be just strictly limited to substance abuse and behavioral health settings. I believe motivational interviewing is the single greatest engagement tool we can employ in modern healthcare. And we often take it for granted and give it lip service. It's not easy to do. It takes a lot of practice and a strong vigilance to making sure that you're not telling people what to do, but you're listening well and you're reflecting back to them what they're saying in a positive manner so that they increase the chances that they'll articulate the right motivation to change their behaviors. When you're engaging with patient populations and you're doing all this motivational interviewing and people do not continue to go with things, when do you call it quits? When are we no longer bound to having to try and find them? Is it after 5 years and no phone calls? Clearly no. Is it after a year and no phone calls and home visits and every attempt to engage them they absolutely refuse? Is it 6 months? I don't know. That'll be up to you and your behavioral health agency's policy. But we've got to fundamentally roll with their resistance at first. That's a component of motivational interviewing. And people have a lot of different needs. And they are always balancing those needs and priorities within themselves. So we have to roll with their resistance and listen to them and try to understand where they're coming from if we have any hope of getting advancement in them choosing better. We've got to, there are technicalities like when you can fire somebody and rules that your agency has governed for case management and care management and psychiatry, et cetera. And so we will continue to promulgate those rules. I think that documenting and operating a registry helps a lot with tracking patients and follow-up and makes it less likely that we necessarily call it quits on somebody. It also challenges us to think critically about what we really need to do to engage somebody. And when we're looking at those outcomes, I don't care what we have to do as long as it's within the realms of legality and we can be cost effective in doing it. If we can get an outcome, I don't care what we do. If we call them on the phone or go visit them in their home, as long as we're doing good motivational interviewing, we're sticking to our basic principles on that. And that leads me to the final point. You know, it's not about when we call it quits, it's just about meeting people where they're at. And if we provide good customer service and listen to them fundamentally, I think we'll learn a lot, and we'll also have a better understanding of what their internal motivations are for whatever. I also have the fundamental belief that everybody wants to do well, live healthfully, and choose well. I have to believe that. If I don't believe it, then I need to leave. And through this basic persistence of using a registry and just being patient and rolling with resistance and meeting people where they're at, I think like a babbling brook creates the Grand Canyon, we can erode things over time. And this is what our systems have to do. We have to be more persistent and more kind and more patient than the people we're trying to work with. And eventually, when they're ready, we'll be ready for them. And the more we interact with them in a motivational interviewing framework and mindset, the greater the chances are that they'll be ready earlier than we ever thought possible. We're talking about building productive, proactive practice teams. That's the point of this webinar. And also informed, activated patients that can have productive interactions. This whole webinar series has been generated focused on preparing this proactive practice team to have these productive interactions. You get an informed, activated patient through health literacy. And you get health literacy by identifying people and utilizing this chronic care model. And then these productive interactions come through understanding of some attachment theory and a better understanding of people and their interaction patterns, and also through things like motivational interviewing and a registry that can help you find people who aren't engaged in their care and follow up with them consistently to overcome those barriers with attachment and negative sense of other that may be barriers to your system recruiting and retaining people. Patient engagement is the final frontier in healthcare. It's the final portion of this webinar series because it is the ultimate goal of these chronic care models. Recovery is patient engagement incarnate. Recovery, when somebody's living in recovery, they are functioning well, they're managing themselves well. We don't have a cure for behavioral health conditions, and just the same as we don't have a cure for chronic illnesses. And so behavioral health has much to add in this world of modern healthcare. As you proceed to build your systems and take part and have a role on teams in your systems, keep some of these basic things in mind, that people are people, they have attachments, and the most problematic and difficult patients are oftentimes the ones that can tell us most about where our systems are failing. Thank you.